Hi everyone, tonight we have another edition of Subspecialty VMR, and this time we have Hematology and Oncology with Dr. Sam and Dr. Lara, and both are from UCSF. And I would love it if they could talk a little bit about themselves, what do they do for fun outside of medicine, and why they chose Hemonc as a subspecialty. Why don't you go ahead first, Dr. Lara?
Sure. Nice to meet you all. My name is Laura Huppert. I'm a third-year Hemonc fellow at UCSF. Outside of medicine, I like to do anything outdoors, hiking, backpacking, biking, etc. So it's great. California is a great place to be to do all of those things. And I chose Hemonc because for many reasons, but I really appreciated the longitudinal patient interactions and all of the really interesting advances in the field in the last decade or two that have really allowed us to meaningfully improve the lives of patients with cancer. So I'm really happy to be here today, and thank you again for the invitation.
Please go next, Dr. Sam.
Sure. Hi, everybody. I'm Sam Brondfield. Great to meet everyone. I love how international this crowd is. So cool to be able to connect with people in different countries over Zoom. So I am in my third year on faculty at UCSF in Hemonc. I specialize in hospital-based oncology, taking care of people who are hospitalized with solid tumors. And like Dr. Huppert was a chief resident at UCSF several years ago and did all my training there. Outside of medicine, my main hobby is actually singing. I do a ton of karaoke, and I'm in the San Francisco Gay Men's Chorus. And we're pretty shut down for COVID, but not totally. And it's been really fun. I chose Hemonc primarily because I just found it to be such a cool intersection between science, like crazy breakthrough, breakneck speed scientific developments, and emotion, just really profound, emotional, deep interactions that are so meaningful. And a lot of fields have those same themes, but Hemonc for me just had the apex of intersection between those two. So that's why I chose it.
Oh, incredible. I just want to ask Franco to introduce himself. He'll be the case presenter for tonight.
Hi, everybody. I'm Franco. I'm a Peruvian physician, and I'm really excited to be here. I think Rafa has been teasing us with this special oncology VMR for weeks, and I'm already all into it. So pleasure to meet everyone.
Thank you for coming, Franco. And we also have Brody that's helping with the teaching points. Could you please introduce yourself, Brody?
Hello, everyone. I think it's my first time after the new year, so happy new year. And I'm very happy to be here. I did not know that Dr. Brondfield sang. I just attended their holiday chorus and it was so good. And I think I even tweeted about it, but anyway, happy to be here. Looking forward to the case.
And last but not the least, our friend Gabrielle, who will be scribing today.
Hi everyone, how are you? My name is Gabriel. Also, same as Roddy, very happy new year. And I hope this is not a 2022, but a 2022 full of happiness and triumph. Thank you so much for this opportunity, for describing today. I'm meeting two incredible people, Laura Huppert and Sam Brondfield. I'm very excited for this episode.
Amazing. Just before beginning, I just want to share a quick story. Actually, a few months ago, I joined a webinar.
Oh, Rafa, you're muted.
God, I muted Rafa. I'm so sorry. I was trying to.
No problem. No problem.
Just
no problem. Just before beginning, I just want to share a quick story. A few months ago, I joined a webinar conducted by Dr. Lara herself, and she was promoting her book and giving incredible tips for medical students to succeed in clerkships. That was a great webinar, and even though I'm from Brazil, her team made sure to send me the book and all for free. And the only thing her team requested of me was to pay it forward and always be kind for my future patients. And that meant a lot to me. And this book has incredible content, amazing figures and explanations. And I loved if Dr. Lara could talk a little bit about why she wrote the book and what it's intended for.
Thank you so much. It's so kind for coming and for promoting it. I appreciate it. So yeah, when I was a medical student and resident, like all of you, I realized that I wanted a resource that kind of combined the pathophysiology you were learning early in med school with more clinical pearls. And I couldn't find anything with the right level of detail as a student and a trainee. And so I started taking my own notes. And kind of by coincidence, got the opportunity to publish them when I was a chief resident at UCSF, and worked with an incredible team. Actually, Sam was one of the faculty mentors too at UCSF to update these notes and really change them, change them into the version that it is today and is published. And the name of the book is called Huppert's Notes because, in reference to them being my original notes, but really they reflect the work of a lot of individuals. But definitely encourage you guys to check it out and spread the word if you like it, because I do think there needs to be more resources like this for trainees, and I hope this is helpful. So thank you for sharing it as well, Rafa.
Our pleasure. And Maria already put the link on the chat if anyone's interested. And Franco, you can go ahead. Gabriel, can you share your screen, please?
Perfect. So the chief complaint is about a 78-year-old female that had complained from tiredness and weight loss for a month. She was fully functional until 1 month ago when she started to progressively feel tired, sleep more, and lose weight approximately 5 kilos. 2 days prior to her visit to the emergency department, she said she couldn't walk without assistance due to extreme weakness. On the day of the admission, she couldn't stand up and looked confused, so her doctor bring her to the emergency department. She never said she had fever or shortness of breath or any other symptoms besides that. It's okay to stop here, or do you want a little more of the previous medical history as well?
Oh, please, Dr. Lara, go ahead.
Oh yeah, you can give us a little bit more, sure.
Perfect. So the previous medical history, she suffered from a stroke 2 years ago without any sequelae. She has also hypertension and surgery for cataracts 13 years ago. She also had a goiter. Her regular medicines are losartan, aspirin, statins. Regarding her family history, her father has diabetes mellitus. She lived in a rural part of the Peruvian Andes through her 20s. So regarding her health-related behaviors, no smoking, but used to cook with wood and used to drink regularly until her 50s. Allergies, no. I think I can stop there.
Great. Do you want me to jump in, Rafa? And perfect. So thank you so much for that great overview. So to kind of summarize, it sounds like this is a 78-year-old woman who was really in her usual state of health until about a month ago. And that's really helpful to understand like when the time course of this occurred. And so it's sort of subacute in the last month. And it sounds like the main complaints are that she is fatigued and has had weight loss of about 5 kilograms or 10-ish pounds for those not as familiar with kilograms like myself. So I think that approaching this, the differential should still be very broad for this woman. I think weight loss for many of us, the question of malignancy certainly comes up because cancer can often cause weight loss, but a number of other processes can also cause weight loss. Progressive heart disease can cause weight loss. Different endocrine conditions can cause weight loss. And so coming at it from that perspective, I'd frame her as someone who has subacute fatigue and weight loss. And that's how I would kind of frame this problem. And I think really helpful before we kind of anchor on cancer here, asking some more questions. Are there any localizing symptoms, and kind of diving into whether we can get more details that'll help us to get started.
Could you please elaborate on that, Dr. Sam?
Sure. Yeah, I totally agree with Laura's framing of this case around a 78-year-old woman with weight loss and fatigue. There was an interesting question in the chat about what's the cutoff for significant weight loss. And there may be technically significant cutoffs and percentages. I'm seeing 10% referenced in the chat. I think clinically for me, what I tend to think about in terms of weight loss is whether it was intentional or not. And really any amount of unintentional weight loss, especially when coupled with other symptoms like fatigue, is automatically really concerning for something going on. And I agree with Laura's framing around the idea of thinking about malignancy early and thinking really broadly about other big categories of disease that would be relevant at this point with weight loss and fatigue, chronic infections that are more indolent, autoimmune diseases, endocrinopathies, especially if we're hearing about a thyroid issue potentially, though sounds like that was years before, but could be relevant now. I heard the family history of diabetes and thought I might have heard a personal history of diabetes, but I might have misheard as well. The new onset diabetes plus weight loss makes me think about malignancy as well, specifically pancreatic cancer, but longstanding diabetes is a risk factor for that as well. So I'm just still thinking really broadly and have my oncology hat on, and I'm worried about an older person with weight loss and fatigue.
And at this point, which pieces of information would you be interested in getting from this patient?
I think I'd be interested in more history in terms of a review of systems would be helpful to see if there's anything more localizing that could be helpful. And then I think starting with a set of labs to see if that leads us in any direction. Just with a CBC, is she anemic? Looking at a CMP, looking at her liver function, her kidney function, thyroid, TSH. I think I'd start there.
Anything else to add, Dr. Sim?
No, nothing else, just general exam and labs at this point. And the thyroid, I think, will be good to check out as well. In someone with systemic symptoms like this, you wonder about when to get imaging. And I would really start without any focal signs or symptoms with an exam and labs to see what targeted workup might be helpful next.
Oh, and one last thing, Rafa. It is helpful, I think, in cases like this, if someone has had health, baseline screening for malignancy in the past, to note that. So has she had a mammogram before? Is she up to date on her colonoscopy? So just that being part of your history taking too.
Good point. Thank you. Please go next, Franco.
Perfect. So to clarify something, she didn't have diabetes. It was only family history. No previous cancer screening due to the Peruvian system that doesn't allow her to go to the cancer screening because of her social history. Regarding a little more about the physical at the emergency department. So the vitals, temperature was 37 Celsius, heart rate 85, blood pressure 120/60, respiratory rates over 20, SpO2 98 on room air. The body mass index was 19. The previous body mass index was almost likely 24. Generally looks ill and sleepy. The thyroid is increased in size diffusely, no tender, no lymphadenopathies. The rest of the HANT was within normal limit. Cardiovascular normal. Pulmonary, there was dullness and diminished breath sounds in the lower third of the left lung. Right was within normal limits. Abdomen non-distended, bowel sound presence, no tenderness, no masses. Neurologically, she looks confused, sleepy, no other focal deficits, normal reflex, no meningeal signs. Extremities and skin, no edema, no rash, but she looked sweaty. She looks ready. I think I can stop there.
So much information here. As a hematology oncologist, Dr. Lara, how would you approach statistical exam findings?
Great, thank you. So of course, whenever I look at a physical exam, I think looking at the vital signs first, just to assess the stability of the patient is very important. And her vitals are more or less okay. Her respiratory rate of 20, just making sure that that's, she's not a little more tachypnic at times, but otherwise she looks stable from that perspective. Of course, we'll note the BMI is 19 from a prior of 24. So definitely true documented weight loss here. And then in terms of the exam, I think the general exam, the doorway exam is really important. And the fact that she looks ill and sleepy is definitely telling that something is going on with this woman, as we knew. And then I think the thyroid exam, like we said, is definitely interesting. We'll want to get the thyroid studies, but makes me wonder whether there is a thyroid issue for sure. And then the dullness and diminished breath sounds in the lung certainly makes me wonder whether she could have an effusion at that side of the lung. We'll want to get, to start with, at least just a chest X-ray. And if she does have a new effusion, consider tapping it and sending basic workup and then potentially cytology on that too, as a way to investigate further. And I think otherwise nothing else too telling. Those are the most important things for now.
And what do you think about this sweaty that she has on physical exam?
Yeah, no, so people can sweat for a variety of reasons. It's possible people sweat often before they're febrile, after they're febrile. So it's possible that her temperature will change, and something to keep an eye on. People can also sweat, various endocrine disorders can cause sweating for sure as well. And so I think we've sort of narrowed in on wanting to get some more endocrine labs. So I think that that's worthwhile.
Please go ahead, Dr. Sim.
Yeah, what an interesting case so far. And there's a lot going on with this person, as Laura's already pointed out. Some interesting things that are coming to mind for me. I'm interested in this 13-year history of goiter. Goiter really just means an enlarged thyroid and doesn't tell us much about what the cause of that is. If it was going on for 13 years, it was very likely a benign cause of a large thyroid at least 13 years ago, but would be curious to know how that was worked up and how that conclusion was arrived at. And certainly you can have slow growing thyroid tumors that then can transform to more aggressive thyroid tumors later in the course. So that's just something pretty interesting about the history so far. That said, I had a patient recently who had a large goiter and came in really sick, and the goiter was totally unrelated. And goiters are not that uncommon. So who knows at this point if it will be related or not to what's going on now. The only other piece I'm zoning in on that I think is acutely very important is the altered mental status and the somnolence. And I'm wondering pretty quickly what the cause of that is. We don't know yet whether this person has a malignancy, but through that lens, or even not through that lens, there's several causes of altered mental status. I usually use the misto-mnemonic. Others may have different ones, but in the context of malignancy and outside of it, metabolic abnormalities are common: calcium derangements, sodium derangements, things that may need to be corrected relatively quickly. Organ dysfunction or failure that's acute, renal, liver dysfunction in the context of cancer can include thrombosis or widely metastatic disease that can lead to organ dysfunction that can cause altered mental status. Thinking about brain metastases and structural things, bleeds. So several acute, possibly concerning cause of altered mental status. And I'd want to get that metabolic workup pretty quick, especially around the correctable, potentially fatal abnormalities like calcium. And also thinking quickly about head imaging if there is concern for malignancy in a case like this. So interested to see what this next round of workup shows around the overall diagnosis and the altered mental status in particular too.
Someone mentioned on the chat the MEG syndrome. Could you please talk a little bit about that and if that fits your illness script so far?
Should I tell about it? Okay. Someone was mentioning a mass in the ovarian region, which could also cause pleural effusion. And for MEG syndrome, it's typical that we have a right-sided pleural effusion together with ascites, and yes, and an ovarial malignancy.
Thank you. Dr. Sam, Dr. Lara, could you please talk a little bit about that as well?
Yeah, I mean, I think that's a great example, a great start, great explanation. Definitely ovarian cancer can be really difficult to diagnose and therefore is often diagnosed late with sort of vague symptoms in many cases. So, dull abdominal pain, some bloating, and can develop ascites and then a pleural effusion like was said. And so definitely the ovarian cancer would be on the differential here.
Oh, thank you. Do you want to say something, Dr. Sam?
No, nothing to add to what Laura just said. Totally agree. It's on the differential. I like that we're thinking about the demographics of this person and what cancers might be the most common. Ovarian cancer is not the most common or on the list of most common cancers, even in older women, but certainly a consideration. More common cancers would be breast cancer, colorectal cancer, lung cancer, but for sure, ovarian is linked to effusions, as are many other cancers, lung cancers, thyroid, many of these things could cause this presentation. So we'll need more workup to find out what the likely primary is if this is cancer.
Thank you. Please go next, Franco.
Perfect. I'm loving the discussion already. So the white blood cell count, say 11,200 with a normal differential. The hemoglobin was 10, MCV 88, HCM 29. The platelets were 198,000. Regarding the chemistry, the glucose was found on 31. After dextrose, it improved to 60 with a little of the improvement of symptoms of the patient. She was awake after the dextrose. The potassium was on 4, sodium 139, calcium 7, total protein 4.63, albumin 2.1, creatinine 0.3, BUN 16, CPK 9, AST 20, ALT 19. The TSH was 0.3, that was low, and the T4 was 1.82. I think I can stop there.
With those labs, did you change your differential, Dr. Laura?
Thank you so much. Just looking through them to catch up. So I think for the CBC, the hemoglobin of 10 is on the lower side, but for someone her age isn't that abnormal. It's always helpful to know the baseline, because if she was 14 before and is now 10, then that would change things. But otherwise, I think relatively normal for her age. Obviously, on the chemistries, the glucose of 31 is extremely notable and alarming. I think tumors like insulinomas that produce excess insulin and can cause hypoglycemia are on the list, versus other reasons that she could have hypoglycemia should also be considered. Whether it's is she on any other medications that can cause hypoglycemia? You wouldn't nutritionally just get that down quite that low unless she's truly not eating. So I think it definitely raises red flags for something more nefarious for sure. And then the other labs, just looking at them quickly, her LFTs are relatively normal. Her chemistries are relatively normal. The TSH is at 0.3 is certainly on the low side. I think getting the rest of the thyroid studies is helpful as well, because certainly she could be hyperthyroid. So again, coming back to whether there's something going on with her thyroid here. So those are the things that stand out. Oh, we do have a T4. Sorry, I missed that. Is relatively normal, but could be worth getting a T3 as well.
Please go next, Dr. Sam.
Yeah, this is an excellent discussion. And as usual, I have very little to add on top of what Laura's already saying. We definitely still need to consider non-malignant causes of severe hypoglycemia, everything from infection to severe dietary restriction, although it sounds like this is not the case by history here. In the context of malignancy, I'm seeing insulinoma in the chat. I think that's a good thought, though certainly a rare tumor, and agree with the chat that there is a hypoglycemia workup that should be undertaken. I will just share from the oncology standpoint that I've seen a few cases now of really severe perineoplastic hypoglycemia that's very refractory to glucose administration. And that's typically due to the release of a substance that causes that through an insulin pathway. IGF-2 is the one that comes to mind. So there is this IGF-2 mediated severe perineoplastic hypoglycemia related to a few different solid tumors that can be really difficult to treat. So I'll just bring that up, having seen that before. But again, these are all very rare associations, and I'm glad that they're giving aggressive glucose, but especially if we continue to have trouble with getting that glucose up, endocrinology may be helpful as well for helping us avoid a bad outcome in this case from the hypoglycemia. I'm really glad the chem panel was checked quickly because we were mentioning earlier what are some of the really severe, potentially fatal metabolic causes of altered mental status, and for sure hypoglycemia is one of them. So glad that was checked quickly.
And as a hemonc, which labs would you be interested to get right now?
I think, you know, working up the hypoglycemia aside from the hemonc side of it, but just to understand that better is certainly important. And then it always comes up like, you know, we're worried about malignancy. Should we check tumor markers and just, you know, shoot off a panel of tumor markers? And I think that different hematologists, oncologists feel differently about this. It sort of depends on the situation. But generally, I think it's helpful to get more information first and not just send a broad panel, because as you know, these shouldn't be screening labs in most cases to tell you what the cancer is. It's like once you have an idea of what the malignancy is, it's more useful to follow those numbers over time, and they can help make the diagnosis. But generally, I don't use it alone to make the diagnosis. And so I think doing other workup first before getting those tumor markers would be my approach.
Amazing. Anything to add, Dr. Sim?
The other thing not to miss in terms of a cause of hypoglycemia and further lab workup would be adrenal insufficiency.
I was just gonna say that, yeah.
And yeah, I know Laura was already thinking about it. And just again, thinking through an oncologic lens, the main cause of that in metastatic solid tumors would be really burdensome bilateral adrenal metastases from a tumor. We also often see endocrinopathies with immunotherapy, just of note, but this person's not on that. But yeah, adrenal insufficiency is something not to miss as well in the context of hypoglycemia and fatigue.
Thank you. Please go next, Franco.
Great. So I have a little more couple of labs. So the 6 cortisol was on 18, LH 25, FSH 40, PDH 52, prolactin 22.5. There was some workup for the hypoglycemia. So the insulin was during this, with the same sample of the glucose in 31, the insulin was 1.4, that was low. The C-peptide was 0.1, that was low. There was also IGF-1 standard that was 46 between normal levels, and IGF-2 of 145, but the index of IGF-2 and IGF-1 was 3.17, that was high. There was also a thorax CT that showed a pleural dependent mass of 16 plus 10 plus 11 centimeters with interior necrosis. I think I can stop there, and the next aliquot will give the final diagnosis.
Please go next, Dr. Lara.
Oh, sure. So for the hypoglycemia workup, honestly, I would have to look at the normal ranges at that hospital and look at those numbers a little bit more closely because I don't have them off the top of my head. But I think really helpful to know that information. And then, of course, the imaging with the large mass, extremely impressive 16 centimeter mass with some necrosis. And so the most important next step, other than the management of her hypoglycemia, which we should definitely keep an eye on and control to make sure that that would be the thing that would actually cause demise fastest. But in terms of the workup for the malignancy, of course, getting a biopsy of that mass. So talking to radiology and figuring out how to safely do so.
Please go next, Dr. Sim.
Yeah, I think this is, again, really interesting case. I think that ratio of IGF-2 to IGF-1, I don't remember the cutoffs off the top of my head, but sounds suspicious to me that that could be the cause of the hypoglycemia and that this could be a paraneoplastic IGF-2 mediated hypoglycemia, especially with the low insulin and the low C-peptide that suggests against an insulinoma. But someone please correct me if my cutoffs are wrong and the IGF-2 over IGF-1 ratio is just noise. And then the workup by imaging, glad we got the chest CT. We've got a mass that looks suspicious for a primary cancer, given its size and no other reported mets on the CT chest that you can have large metastases to. Sounds like there's an associated likely malignant pleural effusion. It's always good practice to tap the effusion as well as part of the workup. So if it's tappable, that actually, I guess on the imaging, I don't even know that there was an effusion found. It sounded suspicious on the exam, but I guess we're not seeing a clear effusion on the CT report so far. If there is an effusion, tapping it would be recommended and sending it for cytology. Pleural-based masses, the differential is still pretty broad. Lung cancer is certainly high on the differential, but metastasis from many solid tumors can go to the pleura. If there's pleural nodularity plus an effusion, you also think about mesothelioma. So still the differential is quite broad, and we'll want to get tissue plus or minus the effusion tapped, depending how tappable it is.
The IGF-2, IGF-1 ratio is actually high. Does it change your differential?
I will have to go and remind myself by looking up what the common associations with paraneoplastic IGF-2 mediated hypoglycemia is. I can't remember off the top of my head what cases I've seen and what the tumors ended up being, but we'll be excited to relearn that from you all so I can remember that going forward.
It looks like in the chat, it said ratio greater than 10 is expected for an IGF-2 producing tumor, which thank you for sharing that. Because yeah, I also don't have a number off the top of my head, but.
And it's always important to note that there can be noise. So yeah, still knowing that ratio cutoff, who knows if this ratio is truly real and truly the cause, though clinically, now that we have a cancer and severe, maybe refractory hypoglycemia plus an abnormal ratio, I'm concerned clinically that this could be an IGF-2 mediated hypoglycemia.
Please go next, Franco.
So as always, this line always comes out and says the tissue is the issue. So it's oncology VMR, so could be expect less for that. So they make a biopsy that show mesenchymal neoplasia with fusiform cells, BCL2 positive, CD34 positive, consistent with solitary fibrous tumor of the pleura. The patient was refractory to the dextrose, so they give her steroids and kind of improve a little bit of the values of the glucose, and she went to a thoracotomy to get the neoplasia out. And after that, the glucose improved.
Thank you, Franco. Such an educational case. And I would love if Dr. Lara and Dr. Sun could talk a little bit about their cognitive autopsy on this case. And also, since we have so many students here, what do you think us should take away from this case?
Sorry, what was your first question, Rafa? Talk about
the cognitive autopsy. Talk a little bit about
sure.
your reflections on this case, and also if you could say like 2 or 3 things as a student should take away from this case as well, please.
Sure, of course. So yeah, I think this is a really, really interesting case and a lot of different pearls to take away from it. I think a few things that we talked about that are really important. So unintentional weight loss, especially in an elderly person, is never something to be ignored, regardless of exactly the number of pounds, and warrants further investigation. So I think that's essential for sure. I think thinking about how to work that up, I think starting with a good physical exam and then a basic set of labs, because the labs will often direct you towards one thing or another and can help you kind of narrow your differential. Of course, we think about malignancy, but like we said in the beginning, chronic infections, endocrinopathies, a lot of other things should also be on that differential. And so a good physical exam, good review of systems and labs will be really helpful. I think the discussion about the hypoglycemia is really interesting and a good chance. I haven't thought about, the workup of hypoglycemia as, recently as I should have, but I think a really interesting point in thinking about the ratio and what the cutoffs are, but keeping in mind that you have to keep the whole picture together here. And so for sure, we're worried about a malignant process, and insulinoma came to mind, but then also talking more about this IGF-2 mediated perineoplastic process. And then finally, like we said, tissue is often the issue in oncology. And so to get the final diagnosis, it is really helpful to get tissue. One thing I feel like I've learned over the course of fellowship is that even getting tissue and getting a diagnosis, talking to pathology directly, especially for more rare tumors, can really be useful. Because we often will see a case and think it's one thing, and then actually after we have a discussion with pathology and send additional stains or additional tests, it'll end up being something different, which we'll treat very differently. And so I think particularly in cases of rare malignancies, it's worth getting the pathology from wherever it was taken, reviewing it again with pathology, and making sure we really understand the diagnosis before we embark on treatment, since it really is a critical step.
Please go next, Dr. Sim.
Yeah, fantastic take homes. I think for students in particular, I think this case is a really great example of a diagnosis in the end that's really unusual. And you can still apply really important general frameworks to help you take care of this person. So this person came in with weight loss and altered mental status, and we talked about misto and found a really severe metabolic abnormality leading to a potentially fatal situation that led to workup and diagnosis of this really rare tumor and rare association. But to save the person's life, the hypoglycemia was the really urgent thing to deal with. So even when you have all these esoteric, strange diagnoses that you may or may not have heard of, you still know the basics of how to save somebody's life. And in this case, the glucose was the key, and ultimately steroids, and then resection of the tumor.
Someone asks on the chat, aren't tumors of mesenchymal origin automatically sarcomas?
You can go for it, Sam.
Sarcomas do come from mesenchymal origins. They can come from any sort of soft tissue or really connective tissue in the body. They're named after usually the tissue that they come from: osteosarcoma from bone, liposarcoma from fat, myosarcomas like rhabdomyosarcoma from skeletal muscle, etc. I think there may be some additional mesenchymal tumors that are not considered sarcomas. These are all super rare, but I think there's a large overlap between sarcoma and mesenchymal origin.
Oh, amazing. Thank you so much for coming. Like, IMONC is such a very tricky subject for many of us students, and it's really a pleasure to learn from such incredible specialists like yourself. Thank you.
Thank you for having us.
Yeah, thank you so much for having us and for all the discussion. The chat's amazing. I just am looking it over and feeling like you all have such amazing collective knowledge. And thank you, Franco, for presenting such an interesting case and reminding us about a really important syndrome and a rare tumor.
And to finish us off, I would love if Brody could share their teaching points.
Absolutely. I think it was a pretty interesting case to talk about the least, but the points that I've tried to get, weight loss, systemic, any kind of weight loss unintentional in a person who is probably old smells of trouble, and probably taken in the context of localizing symptoms and signs achieved through a proper exam and physical. I think I found this interesting. Goiter to be, etymologically, it just means a large thyroid, and could have be different causes. And I think Tiago said that diffuse enlargement is relatively benign. Altered mental status, we go back to our missed mnemonic in the context of malignancy. I think hypoglycemia was the most, I think it was the cause here, which is metabolic, infectious, could be due to secondary infections or as a part of chemotherapy, or structural, which could be the Mets, and there's another, which is the case here, it's paraneoplastic syndromes causing causing altered hypoglycemia and altered mental status. Some other non-malignant causes of hypoglycemia, and I just realized I made a mistake here. I guess it's just causes of hypoglycemia. So it could be infection, dietary restriction. Then for malignancies, it could be either the malignancy itself causing the hypoglycemia in case of insulinoma, or paraneoplastic syndromes, which is IGF-2 mediated, as in this case. And also keep in mind endocrinopathies due to adrenal insufficiency, which could be due to secondary metastasis from other tumors. One thing I kind of found interesting is always interpret the insulin along with the blood glucose. I think Tiago mentioned that. And low blood glucose, low insulin, low ketones, and a high IGF-2 to IGF-1 ratio more than 10 is expected of an IGF-2 producing tumor. And discuss the issue about the issue about the tissue with the pathologist, especially during rare diagnoses. I think those were some of my points. It was a great case. It was really enjoyed it, and thank you, Franco and Dr. Huppert and Dr. Brondfield.
Thank you everyone for coming, such a joy, and I hope to see everyone tomorrow. Actually, we have an amazing session with Dr. Ravi and our friend Kirtan, who will be facilitating. So thank you everyone, hope everyone have a good night and learn something today. Hope to see you everyone tomorrow. Bye. Thank you.